All right, welcome back to the Elias Smacko Show in the second hour of the program. We're going to begin this hour of the show with, as much as we can, an in-depth discussion about the healthcare system and if it's still capable of caring for the people that depend on it. Now, the healthcare system under the microscope, not for the right reasons. Of course, there's Bill 106. That could lead to a big change in the way family medicine is practiced in the province. We also, it seems like every day there's a story, right? Last week, we even had a story about Kleenex being rationed at the CHUM. Of course, the CHUM pushed back on that story. But we've invited two family doctors to come into studio and break down some of those questions and have a discussion here on healthcare in the province. Dr. Laura Sang joins us, and she's in studio this morning. You are a family doctor, of course, in the Lower Laurentians, Dr. Sang. Thanks for coming in.
Thank you so much for having me.
And making the trip here into the big city. We've also got Dr. Elise Boulanger with us, family physician, member of the government's expert committee to improve healthcare accessibility. Dr. Boulanger, welcome to the show.
Thanks for having me.
And you practice in St. Henry, by the way.
I do, yes.
Wonderful. Okay, so I want to start off with Bill 106, okay? And I want it, because the government says, listen, we want to move some of the pay of family doctors to be based on performance. Me, average citizen, I hear that and I say, sounds good to me. I mean, like every single job should have some sort of performance-based part of it, right? I feel like that could be a good thing, but I'm not so, obviously I'm not a doctor. I don't know how it is on the ground. So Dr. Sang, I'm going to start off with you. The move to have some of pay, not all of pay, but some of pay tied to performance. How do you see it?
It's such a complicated, issue to work through because how do you judge performance, right? It's so variable from doctor to doctor based on their practice, their patients. I know for me, with the AMPs that I have, the two places that I'm mandated to work in my region.
You said AMP. What is an AMP?
So it's pretty much these mandated activities, 12 hours a week that I have to do for my region, obligatory. And I'm always divided between the two places of work. So when I'm at one place, colleagues have to cover for my patients at the other. Mm-hmm. So if we're measuring how many people are coming, on a walk-in basis on a day that I'm not there, that could impact me unfavorably. And because I'm always in two places, I can never be there for my patients as much as I want to.
Dr. Boulanger, what are your thoughts?
Yeah, and I think Laura alludes to a good point, is how you measure performance. And I think people in general are not, against performance in itself. I think it's something that's been done in other jurisdictions as well. I think the issue that we have with what has been proposed thus far is that the proportion of performance is very high. 25% seems really high, whereas most other places that have looked at this in terms of incentivizing doctors to do certain activities and certain things a certain way, look more at maximum 10% possibly, and really look more at indicators that touch on quality, right? Versus volume of acts. And I think this is really an issue that we have currently, is that we have really difficulty to assess what is the quality of what we do in primary care, right? Like when we work in our office, we know what this means, right? It means taking, the globality of a person's issues and understanding their context. This takes time often, right? And having these continuous relationship with people, trying to give them good access when they call the clinic, things like that, right? But these are not things that we measure right now efficiently, let's say, and that would be sort of possible to measure performance on this. And the other thing is that people on the ground right now don't have any indicators to measure their own performance. So now we want to tell them, okay, now like this large proportion of your remuneration is going to be on performance when they don't even know where they start from and have no means of improving on that.
So listen, and I know there are some doctors, they're close to retirement age and they've decided, I want less of a workload. Totally understand that they wouldn't want to work, a full-time slate. I get that. And this may be a tricky question for the both of you here. Are there some doctors, some, not all, some, that aren't working enough, that have just made a decision, I'm going to work less hours, I'm going to work less days, and that should see a pay cut because of that?
So I mean, there's probably some that choose to work less. Right now, the way that doctors are paid is fee for service, right? So if you work less, you see less patients, you are paid less, okay? It's not a salary where people are salaried and then choose to work less days, right? So the people who do work less are paid less. The people who work a large amount do get more money. So it's really incentivizing the volume of activities. That's what we're doing.
So why is the government so hung up on this, it seems?
I think that there's a misunderstanding of what they mean by 30% of people, who probably aren't working as much, quote unquote, as they say. And I think it stems from the fact that the way that they assess the number of days that people work is based on days billed with the régie, the RAMQ. And it takes a certain amount of things to be billed, to be considered a full day. The other thing is that there's many activities that doctors do that are not accounted for. So all the management, managing your results, managing all the stuff that comes back from what we order to patients, the forms that we need to fill, all of those things, on top of it, when you teach. So lots of doctors are involved into teaching. And then that's it. So there's a coordination that you need to do with others. There's some conferences you need to go to. For example, I do a lot of, I get involved a lot with the Quebec College of Family Physicians. That's a lot of work that I do to improve my profession, to work on, how we can work better. And that's all in the benefit of patients in the population. But that doesn't account, right, into my hours worked as a doctor.
Dr. Sang, what is the part of this that we're not talking about? The part of this equation when it comes to performance and what the government's trying to push and that maybe we haven't talked about yet?
I feel like it's really focused on doctors and family doctors in particular, but they're ignoring all of the other, things that are required to deliver healthcare. Nurses, social workers, physio, access to all of these things. I can't even count anymore how many of my patients I have to see regularly for CNSST visits who are not getting better because they're waiting to see a specialist and they can't afford physio and they're having trouble finding a physio who's covered under CNSST. Just to give an example.
Jeez. Yeah, well, that's a pretty good example, right? And now on the paperwork front, because I've heard this brought up before, has the government made some moves that you're in favor of? I've heard that they want less doctor's notes and less duplication of forms by multiple people. Is that actually happening? Are they actually making a change in your job in that front?
Personally, I haven't seen much of a difference because that also is part of the practice that I have, that most of my patients are retired. So coming in for a doctor's note for missing work was never really a thing. But I feel like the bulk of my time is actually taken up with sort of the government tax forms, more prolonged leave. A lot of insurance companies have these very detailed forms and can be a little bit aggressive if I actually haven't filled them out within a certain time frame.
Okay.
Yeah, and I think there's an issue as well of the all of the systems that we work with don't currently necessarily speak together. So apart from all of the forms that we have to fill, it's often also the detective work and the digging that we need to do to understand a patient's full situation. If they've gone to the hospital or if they've gone to see a specialist, half of the time, often we don't necessarily receive information from those specialists, and I don't think that's because they necessarily are trying not to do their job. I think sometimes it gets lost in the system and there's no efficient way to transferring them. So searching this filling form, asking the secretary, can you request what the result of the test that we sent the patient to do at the hospital? So doing all of this coordination work as well is a big issue. I think the government is trying. I know but it's a big problem, and I think technology will be helpful in solving this issue, but we haven't seen,
technology in what way? You mean digital files or artificial intelligence? When you say
interoperability between systems, better digital information as well that we can search, things on one platform that's quite usable, that allows us to save some time, and that is, adapted to our workflows, and that we really it gets outside of the, we used to have these paper charts where you used to flip. It's almost basically often where you have this on your computer. So it's like the potential of technology is not realized in this, where you can actually use it.
It seems like the government has a lot of like one size fits all solutions. And I just want to pick up on something you said, Dr. Sang, about, like in your practice, you have a lot of people that are older, right? And I'm wondering, do you find that's an issue here? Like, some family doctors have a clientele, or the people that they see are up there in years, and then other family doctors, maybe, they have more people that are in their 20s, 30s, 40s that have less medical issues, but both of these doctors are treated the same way. Do you feel, is that an issue?
I mean, I think so, in the sense that just to say that someone is younger doesn't necessarily mean that they're going to be healthier. That there's, how you define health throughout the ages is quite variable, but it's very different challenges. So I know for me in my practice, that's very, older adult heavy. I struggle to get a lot of, referrals for internal medicine, for respirology. A lot of my patients were heavy smokers throughout their lives. So I'm struggling to manage those sorts of things. Whereas my younger patients in their 20s, it's a lot more, mental health issues. I'm struggling to get psychiatry. So we're both struggling, but I feel like, depending on your practice, it's different kinds of struggles. The resources that you need are different, but you're still working just as hard, in my opinion, to get the care that your patient needs. It's just the kind of care that they need is different.
Continuing our discussion on the healthcare system, joined this morning by two doctors. Dr. Elise Boulanger is with us, a family physician, member of the government's expert committee to improve healthcare accessibility. And Dr. Laura Sang is with us, a family doctor in the Lower Laurentians. Okay, so I want to keep going on the thread that we were discussing here. And, some people are sending me notes listening to us here, and they're talking about bureaucracy, people getting in the way, middle management, that kind of thing. So let's start on that. Dr. Boulanger, when it comes to our healthcare system, is there too much bureaucracy standing in the way of providing care?
I think there is still too much bureaucracy. Yes, probably. There's a lot of, we were talking about forms before, but a lot of forms to be able to refer people to different, trajectories or services that are outside of our clinic. And that takes a lot of time for sure to handle. I think it's in the way as well, probably, that primary care, if I speak for primary care, because that's more what I know, is there's a bit of a lack of a kind of a more systemic, how can I say, like governance of primary care as a whole, that maybe makes it more challenging to be able to coordinate all the different parts. So you have, what's happening in the clinics, and then you have all these programs related to the CLSC, and then you have, depending on different services, they may be found with other professionals also through the CLSC, but it's a different direction. And so, and then you have, the connection that you have to be able to make with specialty services and other professionals that may not be in your own, healthcare, like in your own clinic, that you have to relate with. And so, it's very difficult to sort of coordinate all these actors. And that definitely creates a bit of a bureaucracy, but because it's not sort of under one umbrella, it's hard to coordinate properly.
Does the government consult enough? Because I did point out, right, that you're on the government's committee to improve healthcare accessibility. So do they do their fair share when it comes to consulting? Because sometimes I hear it's too top down, or the only province that does it a certain way, or the government controls so many things. So are they consulting enough or not enough?
I mean, I think the expert committee that we took part on, me and my colleagues, I went on this committee with Professor Mylène Breton, who's a researcher in Sherbrooke University, and Dr. Antoine Gros, who's a family physician, also a scientific director of Unité Soutien, which supports translation of scientific data to practice, and basically, I think that the goal to ask us to look at how primary care is organized in Quebec was a very good idea. And the point of our work was to use this to create a policy for primary care in Quebec. And what we did is we went to look at what's being done elsewhere. So in other jurisdictions, we also looked at what the science tells us that how we should arrange, how we should organize primary care. And we came and we consulted with about 200 people here in Quebec to see, okay, so it's good. This is how other people do it elsewhere, but we know that we can't just apply what's being done elsewhere to our own context, because that's not how things work. But we need to understand what works, what are the key ingredients, let's say, what makes the bread, raise. And then by consulting, we were able to give recommendations on how we should do this in Quebec. The report just came out, right? We did it very intensely, very quickly over several months, but it just came out in April. So we're hoping definitely that the government will use this to move forward. The current situation with the project, the law that is
Bill
want to put in
106.
place was a surprise to us. I think it's definitely not something that we had, in our recommendations. And I think at this point is maybe not helping the engagement. Yeah.
Dr. Sang, I want to do the impossible here, and let me just make you ruler for a day, right? Where you got the magic wand and you go, poof, we're going to try and fix things. What would you change? What would you do if you had decision-making power here on how we deliver healthcare in this province to make things better?
So the first thing that I would do is I would allow more flexibility in the way that family doctors practice. I think that having try to create positions to incentivize working in regions that need it should be done, with a reward-based system and not necessarily a punitive system. But allowing people to work within their means will lead to better job satisfaction, better retention, less burnout, and people who may have otherwise retired being able to continue working for longer.
Do you see that, by the way? Do you see some of your colleagues that have left?
Yes. And I every time something new happens, there's the discourse amongst those who are on the brink of leaving. Do I stay? Do I go? And it's usually, okay, well, we'll wait a month or two and see what happens. But if this happens, I'm leaving. Oh, okay, it didn't happen. I'll stay. But it's every couple of months that there's a big discourse amongst.
When they leave, where do they go?
Oh, well, they retire early.
Wow.
And my younger colleagues, I know some of them, there's documents circulating on how to get licenses in other province. A lot of people are looking into backup plans just in case that, with the life that they have outside of medicine, if it's no longer feasible and they have to relocate.
Why do you think in Quebec we have such a growing prevalence of the private system as opposed to other provinces? Why would you say that is?
I think it's a mix of things. It's, doctors wanting to have more control over the type of practice that they have. There's so many ways you can practice family medicine. And if you're interested in a specialty that isn't offered amongst the mandatory activities, or is, for example, I know a lot of people are interested in sort of more cosmetic surgery, that would be under the private. It's not covered under RAMQ. So that's sort of one aspect of it. But I also think similarly, a lot of patients and people out there who don't have family doctors, private is literally the only way they can access someone. I have colleagues, medical colleagues of mine, who do not have access to a family doctor. And when they have an issue, the only way that they can, without waiting outside in line at 6 a.m. So that they don't have to cancel their clinics, is by going and seeing a doctor who works in the private sector. That's the only option some people have. Dr.
Boulanger, to wrap us up, how do you view the private side of the healthcare system right now and the role it's playing?
I mean, I think definitely in Quebec, we're one of the provinces that has more of that for the reasons that Laura mentioned. And it doesn't help to strengthen, our system, our public system, because, those are resources that we're trained in that we don't have now in the public system. But I think it speaks a little bit to a lot of uncertainty that that providers may feel in Quebec and sort of make different decisions based on that. And that uncertainty is not helpful when you're trying to build a system where, you really want primary care to be strong, because a good healthcare system, a strong healthcare system relies on a strong primary care system. And for that, we need everybody. And we it's terrible that people don't have access right now to this, and they should, because it's kind of the basics. So I think that we need to really kind of focus on how we can build this strong healthcare system for everybody, and we need the engagement of providers to do that. So,
Dr. Boulanger and Dr. Sang, I want to thank you for coming in. Luckily, I have a family doctor, so I will not give you my personal issues and try and get your advice. I'll go to my family doctor for that. Thank you so much for taking the time for our listeners this morning.
Thanks for having us.
Dr. Elise Boulanger and Dr. Laura Sang on the program this morning.